Welcome to the Silicon Valley Health Institute. For about 20 years, we've been inviting some of the world's leaders in health to give talks in our forum. And we're a forum where the members can contribute, and typically in our real meetings, we have questions and answers where the audience can ask their health-related questions. So currently we're having weekly Zoom meetings, and whenever we get back together to meet with people, we will be able to continue with our Zoom, with occasional Zoom meetings for those at a distance. Anyway, we are honored today to have Dr. Joseph Pizzorno. Have you heard of Baystar Naturopathic College? He founded it. So he's a world-leading authority on science-based natural medicine, a term he coined when founding Baystar University in 1978. A naturopathic physician, educator, researcher, and expert spokesman, he's the editor-in-chief of the PubMed Indexed IMCJ, treasurer of the board of the Institute for Functional Medicine, board member of the American Herbal Pharmacopoeia, and is a member of the science boards of the Heck Foundation, Gateway for Cancer Research, Bioclinical Naturals. He is licensed in Washington and a recipient of numerous awards and honors, such as the IFM Linus Pauling Award and the AHMA Holistic Medicine Pioneer and the AANP Naturopathic Physician of the Year. He was appointed by Presidents Clinton and Bush to two prestigious commissions advising the government on how to integrate natural medicine into the healthcare system. He is a co-author or author of 5 textbooks, including the Textbook of Natural Medicine, Clinical Environmental Medicine, and 7 consumer books, Encyclopedia of Natural Medicine, The Toxic Solution, etc. So we're really honored at having him today. So thank you for joining us. And this will be posted on our website at www.sbhi.com. So I give you the floor.
Well, thank you. Thanks for the kind introduction. And I'm actually looking forward to doing this lecture in a little different way than I have in the past. So I have 94 slides. So I could easily talk for the next 2 hours just on my slides. But what I'd rather do is kind of cover a few slides and then talk about what they mean and make this more of an interactive process. And if that means we don't get quite to the end of my slides, I don't think that's a problem. So that sound good to you, Susan?
Sounds great.
Okay, so let's get this working. So now I've got to share my screen. Now I'm going to bring up my PowerPoint. Okay, can you all see this okay?
Yes.
Okay, great. Okay, so let's just, I'm gonna go through a couple of things very quickly. So what I thought is I talk about how 4 toxins in the environment are contributing the most to chronic disease. And the good news is that while the data is pretty scary, we can do something about this. So that's why I do these lectures, is we can do something about this. Now, a very important factor here is, I think everybody's aware we've got a worldwide epidemic of chronic disease. Basically, every chronic disease has gone up in every age group. And while the drug apologists will say, well, people are getting older, therefore it's normal to have more disease. The reality is that yes, it is common to have more disease as people get older, but the reality is that every age group has way more disease than ever in human history. And I'll be using diabetes as an example because the data there is so good. And then I'll show about how toxins are the primary causes, what disease they cause, how they cause disease, where it comes from, and how you assess it, and then finally, what are some strategies for getting these things out of the body. A key point I want to make on this slide here is that this is human data. We're not talking about theoretical, we're not talking about cell culture, we're not talking about animal studies. This is human data. So this is real. This is affecting people right now. And I know we have a lot of clinicians on the lecture right now, and every patient you're seeing, I would assert, is being damaged by environmental toxins. The only question is not that they're being damaged, is how much are they being damaged and which ones are doing it. So when we start looking at, I'll stop for a break in a second. So we start looking at diseases. I just grabbed a few. ADHD, for example, up dramatically. Kidney disease, we have an epidemic of kidney disease. We look at diabetes, literally all over the world, we have this increasing incidence of diabetes. And I say all over the world because I literally lecture all over the world now on how environmental toxins have become the primary drivers of disease. So this is a good break point. Any questions or comments? We can discuss this. No comments, no questions. Okay, continuing. Okay, so let's spend some time diving into diabetes. So as you can see, diabetes has been going up relentlessly. So I was in naturopathic medical school way back here. Diabetes affected about 1% of the population. Now it's up to about 10% of the population, with 1/3 of the population projected to get diabetes in their lifetime. What happened? Our genetics didn't change. That's pretty clear. So how about sugar consumption? And it's clear we consume way too much sugar. As you can see, looking at going back, literally 200 years ago, from basically almost no refined sugar whatsoever to now a significant portion of people's consumption of calories and pounds per year, lots more sugar. But here's the kicker. The diabetes epidemic didn't start until here. So if sugar was the cause of the diabetes epidemic, why don't we see a better correlation? There's a 40-year gap between the peak here. Notice it was going down. Okay, and then started going up again, but this doesn't correlate with us having 10 times as much diabetes and 30 times as much projected in the general population in their lifetime. Something substantial is different. So next we want to look at is obesity. Very, very clearly. People who are obese have dramatically more diabetes. So look at people who are morbidly obese woman, 93-fold increased risk of diabetes. That means she probably has diabetes, just hasn't been diagnosed yet. And same thing with men, 42-fold increased risk for diabetes. Probably have the diabetes already, just hasn't been diagnosed yet. Okay, but here's the kicker, and this is what grabbed my attention. I was asked to design a corporate wellness program in Canada about a dozen years ago. And the guy who asked me to do this is one of the richest men in Canada. And so he sends his personal Learjet down to Seattle to fly me to Calgary to talk to him about developing a corporate wellness program for his 4,500 oil field workers. And so I said, well, yeah, I'd be happy to do that. I've got a lot of knowledge on how to apply nutrition for people and things of this nature. But I said, yeah, I'd like to do it objectively, which means to me, measure. So I said I want to measure people's nutritional status, I want to measure metabolic status, and there's some toxins I want to check as well. How much can I spend? He said, blank check. And he said, if you can convince me we should run the test, I will pay for it. And by the way, pay for this out of pocket. So I ran $1,500 of lab tests on 4,500 oil field workers, looked at what I found, intervened, and then treated them again and got improvement in their health. So as I was looking at this, I was saying, whoa, there's lots of diabetes, and there's a lot of ill health here. And these are relatively healthy people. These oil field workers are mainly men in their 30s and 40s. There's other population as well, but they were the main ones. I've seen all this disease. I've seen lots of toxins, seen lots of nutritional deficiencies. When I checked about 10 different nutrients on 4,500 oil field workers, and out of that whole group, less than 1% did not have at least one nutritional deficiency. 50% had multiple deficiencies. So nutritional deficiencies were very common. But anyway, I was seeing a lot of disease. And I started looking at research on the increased incidence of disease. I specifically looked at diabetes first because that was the one popping up the most. And I started looking at these numbers and saying, whoa, look at all this diabetes. And then I said, well, look at all these environmental toxins I'm finding. Is there a correlation between body load of environmental toxins and incidence of diabetes? And I was saying, wow, look at that. Look at people at top 20% of body load of toxins versus bottom 20% of body load of toxins. Wow, they got more diabetes. And I started looking at other diseases. I started looking at cancer, and I started looking at dementia, and I started looking at multiple sclerosis, rheumatoid arthritis. All these common diseases cause all this trouble. And people at the top body load had way more of these diseases than people in the bottom load. So now let's get back to the slide. So obese people have dramatically more diabetes. And so most of the explanation right now for diabetes is people being obese and getting and lack of exercise. That's fine, but look at this. If you look at people who are obese in the bottom 10% of body load of environmental toxins, they have no increased risk for diabetes. So here I just said, everybody knows people who are obese get diabetes, but if their fat is not full of toxins, they don't get diabetes. Right? Isn't that interesting? So then here's some research. This come out from the research of a woman named Becky Lee. She's a researcher out of South Korea. So she's the first one just about 10 years ago now, started publishing articles about the correlation between body load of environmental toxins and incidence of diabetes. And here's a little national graphic she put together. So across our vertical axis here, we have the prevalence. So this is not risk, folks. This is prevalence. They already got the diabetes diagnosed. Across this axis is our body mass index. And across the z-axis here is the quintile of body load of 6 persistent organic pollutants. That's just 6 of them. There are now 100 toxins in the environment at doses high enough that's known to induce disease in humans. So let's look at this. So across here, bottom 20% of body load of environmental toxins. Look at this, virtually no impact of body weight on the incidence of diabetes. You take a lean person who we would not expect to get diabetes, those in the top 20% of body load of environmental toxins, 30% of them already have diabetes. But how about the poor person who is both obese and high body load environmental toxins? Look at this. 60% of them already have diabetes. So I ask of you, what's the cause of the diabetes epidemic? And by the way, this data is available for tons of other diseases, which we'll be talking about in a moment. Okay, so that's a good stopping point. Actually, I'm going to make a little change in my presentation. Let me just turn this guy on here. It helps me to know what my next slide is so I don't duplicate my comments. Okay, can you still see okay? Yes, okay, great. Okay, so any questions about this? Any comments? It's supposed to be an active learning experience, not just me nattering at you for the next 2 hours. So somebody say something, please. Make sure it's working.
I'd like to ask if you're going to directly deal with the question of how do you get from high toxic load to a low toxic load if somebody's in one of these situations?
Yes, we'll get to that. I'll do that by toxin. We'll talk about 4 key toxins. I'm not going to assert that they are the 4 worst toxins, but there are 4 of the top 6. Okay, so we'll get to them, each one of them.
Great.
Anything else? Okay, so my next step when I was looking at this toxin disease data was I thought, well, let's go over to the CDC, the Agency for Toxic Substances and Disease Registry Priority List. So this was a list developed by the CDC, well, by the government agencies, to help advise the government on what toxins are most concerning. So they looked at the body load of the toxins, they looked at, in terms of the general population, they looked at how toxic these things were, and then they had a third category, and that is how much of these are in toxic waste dumps to help drive policy. But when I looked at this, arsenic, number 1, lead, mercury, vinyl chloride, polychlorinated PCBs, as you can see, there are a lot of toxins here cause a lot of trouble. So let's look at this in more detail. So the data I'm going to be showing you now comes out of this 2019 CDC report that looks at the sources of the levels of toxins in the general population. So all the data I'm showing you, by the way, it's all research driven, so there's be no question about that. Some screen stuff I don't need. Okay, still here?
Yep.
Okay, good. Go away. Okay. Anyway, so that's where the data is all either government data or it's stuff I pulled out of PubMed. And we're going to start with the worst toxin by far is arsenic. The numbers I'm going to show you in arsenic are simply stunning. So first off, people might think, well, why do we have high levels of arsenic? You might think, well, you only get arsenic if someone's trying to poison you. Well, it turns out that many of the public water supplies in the United States are contaminated with arsenic at levels known to induce disease in humans. So this is looking at the amount of arsenic in various supplies. So white means it hasn't been tested, and this by county here. Green means low levels and going up. Yellow is starting to be a little problematic. 10 micrograms per liter of water is considered to be the threshold for increased toxicity. And that threshold was developed from many sources. The best one I saw was a study done in Italy, and it was a prospective study. I don't know about you folks when you're looking at research, but I really like prospective studies because you're not manipulating the data, right? Consciously or unconsciously. So 20,000 people followed for 20 years in a province in Italy where they had different levels of arsenic in the water supply. They simply looked at what kind of diseases showed up with these people. And I'll be showing that data later on. But they found the threshold. Once a water supply gets above about 10 micrograms per liter of water, that's where you start seeing all the disease. So 10, all the orange ones are problematic, and 50 is really serious, and there are tons of water supplies above 50. Now here's the kicker. 10% of the public water supplies in the US have levels 10 and above. And you might say, okay, well, it's only 10%, but here's the big kicker. Only 50% of the public water supplies have reported their arsenic levels. This is a $50 test. Why have half the public water supplies not reported their levels? Well, I'll let you decide how paranoid you want to get about answering that question. Okay, then we start looking at private water supplies. Okay, well, it turns out a lot of private water supplies are heavily contaminated with arsenic. And by the way, that contamination can be both industrial and natural. So many rocks have arsenic in them. So if the water supply is coming from rock that has arsenic in it, some of the arsenic is going to be leaking into the water supply. That's pretty common. But you also have industrial contamination, and arsenic has been used in so many ways in industrialization. In particular, though, if you look over in areas like here, like in Maine, there's some wells in Maine with arsenic levels up to 3,000 micrograms per liter of water. So there's some areas that are highly, highly contaminated. So arsenic is widely distributed. Next, we look at arsenic in the soil. So arsenic in the soil is going to get there from industrial contamination or agricultural contamination. It also can get there from the water supply. But we also have many surprising areas of contamination in cities. So this is a study that came out of Portland, Oregon. So this came out of some work that was being done by one of my staff people. We are trying to answer the question, how much is a person being exposed to environmental toxins from their air and water? And can we determine that from their zip code? So it turns out the EPA has this huge database looking at the toxin levels in air and water according to county. I wish they'd done it according to zip code, but they did it according to county. The problem with doing it according to county is some counties have multiple zip codes. So it gets a little difficult to figure it out. Anyways, I had this science technology person diving into deciphering this big database. So we put it into the artificial intelligence system that my team created. And she was stunned. She lives in Portland. And she was stunned to find a hot spot right next to where she was living. So, wait a minute. Why is there so much arsenic and cadmium in this area? And it turns out it was from small manufacturers of colored glass for doing stained glass and things of that nature. So they were releasing toxins into the environment. They were approved by the state, EPA approved, but their methodologies were dumping all these toxins into the environment. So you have all these little hot spots all around either colored manufacturing or something similar. So you might think, well, we're living in the city, there's not a lot of industrial activity here, so I don't have to worry about it as much. No, there's plenty of industrial activity causing problems like this. Okay, so now, is arsenic a problem? So let's look at toenail arsenic. You might say, well, wait, why are you looking at toenail arsenic? So the reason to look at toenail arsenic is that it gives you historic exposure. Arsenic is a toxin we're actually quite good at getting rid of. And I define good at getting rid of based on what's the half-life. So if you have a relatively short half-life, that means that we have, as a species, as we evolve, we're being exposed to either that particular toxin or similar toxin. So if you think about it, a lot of water supplies are naturally contaminated with arsenic. So we as humans are actually pretty good at getting rid of arsenic. Half-life 2 to 4 days. Now I'll get into the genetics of this in a moment because this data actually is much broader than just 2 to 4 days. But nonetheless, for the average person, stop being exposed, you'll get rid of the arsenic. Pretty simple. So the reason to use toenail arsenic is so you get a kind of average over time. If you try to just use blood or urine, And by the way, almost all the research that's been done epidemiologically, they look at urinary arsenic levels. And urinary arsenic levels correlate very, very well. But they're only valid if the person is in a consistent environment. So let's say you have somebody who's working on the farm, this is California, in the San Joaquin Valley, okay? And there's high arsenic levels there. They're getting sick. They decide to come to the big city. And while coming to the big city, well, they say, okay, we're going to spend a few days here, go to a movie, get some groceries, whatever. They don't actually see you for 3 or 4 days. Well, if you measure the urine at that point, you're going to miss the arsenic. Toenail arsenic gives you averages over months. So as you can see, over months, as arsenic levels go up, so does diabetes. And what's the mechanism of action? 2 things are going on. Number one is it directly poisons the pancreatic cells producing insulin, the beta cells in the pancreas. And they also do some epigenetic modulation that makes it more difficult for us to metabolize sugar. Okay, so now we see, okay, it contributes to diabetes. So I'll show you some more data on that in a second. But here's the big one. Arsenic is the main cause of cancer. Virtually nobody I talk to is aware of this, but the numbers are stunning. Now, one caveat, this was done in Native Americans. It is possible Native Americans have a genetic susceptibility to arsenic. I haven't seen anything that makes me think that's true, but I haven't extensively ruled it out. So this, with that caveat, just go forward. So they looked at, big study, almost 4,000, and they looked at their arsenic levels and looked at the cancers. And what they found was, as arsenic levels went up, so did the amount of cancer. And they asserted that between 25 and 33% of all major cancers, lung, prostate, pancreatic, are due to arsenic. And liver is no one, with one exception, and that is the lymphocyte, or you might say the white cell and hemopoietic type cancers was an inverse correlation. So for some reason, arsenic is protective against these cancers. So if you include this, then you can see here's the notes. But if you remove the blood cancers, then this number here from the overall cancer number for all non-blood cancers is pretty dramatic. Okay, how about a break for any questions or discussion?
I'd like to ask about the inverse relationship between arsenic toxicity and selenium nutriture. And I noticed on the map that there seems to be a kind of correlation between the two of them geographically. But I'm also noting that selenium seems to be reversely correlated with cancer incidence as well.
Great observation. So selenium and arsenic are examples of trace minerals that compete with each other. So just as arsenic causes more damage, the more selenium is around, the less damage that happens. So good observation.
We have some people that made some questions about like mercury amalgams and toxicity. Do you want to wait to that point, or
Yes.
do you want to discuss
We'll get to that.
Okay.
Another quick question on arsenic. I'm wondering what percentage comes from rice?
Ah, great. So there's 3 sources of arsenic, 3 primary sources of arsenic: water, rice, and chicken. Now, right now, water is considered the most important, but rice and chicken are not far behind. The problem with rice is that if there's arsenic in the water that the rice is being grown in, for some reason, rice is particularly good at absorbing the arsenic. And it doesn't matter whether it's organically grown or conventionally grown, chemically grown. If there's arsenic in the water supply, the rice will absorb it. Now, chicken, up until relatively recently, arsenical compounds were a standard of care for an animal husbandry around chicken, because they would give the chickens arsenic to kill off the parasites that they're experiencing. They also gave it to them because it made them plump up and have more white meat, which is commercially more desirable. So up until recently, it was intentionally and expected to be added to the chicken feed and such. It's no longer legal. It's not quite illegal. And I would have thought, well, I'll show you. I'm not going to say that yet. I'll show that in a second. So the reality is, yes, rice is a significant source of arsenic, as is water and chicken.
Yeah, isn't that a big problem in Bangladesh?
There's a huge amount of research out of Bangladesh because for some reason there's huge amounts of arsenic in that area. Okay, continue. Okay, so now here's this arsenic study I mentioned. So there's done for males and done for females. I think I only have the male one on this particular set of slides. Anyway, they're looking at arsenic levels and looking at this 10 to 20 micrograms per liter of urine. This is greater than 20. Then looking at all-cause mortality, myocardial infarction, ischemic heart disease, lung cancer, atherosclerosis, COPD. As you can see, it's hugely, hugely problematic. Again, 20,000 person, 20-year prospective study. Now here's a slide that I think is really interesting. So this came out of that book I showed you to begin with, where they track over time the levels of various toxins in the body. This is very useful. So this is looking at over this period of time from 2003 to 2010, because that's what's in that book I just showed you. And then just looking at what the geometric mean is, look at people in the 50th percentile, 75th percentile, 9th percentile, et cetera, et cetera. So here's what we look at. The 10 micrograms per liter of urine is the threshold for increased disease risk. What portion of the US population is above that? Look at this. 35% of the US population exceeds the known threshold for induction of disease according to arsenic. Are you aware of many other factors that are caused, that 1/3 of the population is at risk at causing major diseases like cancer, heart disease, and diabetes? Just stunning. So then next thing I like to look at, what are the trend lines? And the trend lines, look, the average amount of arsenic has been going up. It's a little scary. Now, it fluctuates a bit, but the amount is going up. And look at this group over here. These are the ones with the biggest damage going on, most levels of arsenic. Look how much it's gone up. Look at people in the top 5%, that portion of the population have gone up 50% higher level, almost about 1/3 level, increased amount of arsenic in the body. So this is a problem, and it's getting worse. One of the things that makes arsenic so, let me stop there for questions. Okay, continuing on. Okay, one of the things that makes arsenic so interesting is that the form of the arsenic has a huge impact on its toxicity. So what we see in our water supply is inorganic arsenic, okay? And it has, according to the type, what the oxidation factor is on it, its toxicity is between 8 to 26 milligrams per kilogram of body weight. Now, when we detoxify, we go through a two-step process, which I'll show you in a moment. First, producing monomethyl arsenic acid, we'll say MMA for short, which is actually substantially more toxic than inorganic arsenic. Then we have DMA, dimethyl arsenic acid, or DMA for short, which is far less toxic. So body first produces this highly toxic form, and then it's supposed to immediately produce in this much less toxic form. Now, the kind of arsenic that's typically found in seafood is arsenobutane, and that's basically non-toxic. And also seafood is high in, as mentioned earlier, selenium. So it helps protect you from this. So here's the big factor. In order for us to get rid of arsenic, first we have to convert it into the right form. And by the way, notice it requires glutathione. So you have a patient with depleted glutathione, you must consider that they may have more problems with arsenic because they can't convert it to the form that we detoxify. Then we go through a methylation process, and that methylation process produces, again, a more toxic version, about 8 times more toxic than inorganic arsenic. Then we go through a second methylation process and produce DMA, which is now 4,000 times less toxic than inorganic arsenic. And here's what's happening. Because of genetics, some people make this first version go very, very well, but then when it comes time for the second version, they have trouble making it go. So people with fast version here, slow version here, way more toxicity to the arsenic. You've probably heard that before. Remember with the liver detoxification of chemicals, we got phase 1 and you've got phase 2. And we know we have some people we call hot detoxifiers. Their phase 1 is working just great, but their phase 2 is not working very well. So they have all these activated intermediates that are way, way toxic, more toxic. So it turns out a significant portion of the population has one or more polymorphisms that significantly impact this toxicity factor. I'll get into that in more detail. Okay, so reduced glutathione. So here's what's fascinating. more and more I've seen research looking at both nutritional status and toxic status. And it turns out when a person is nutritionally deficient, they're way more susceptible to toxins, which I'm sure it's not surprising to anybody. So looking at this, so here in this situation, here we have a person with low levels of glutathione, reduced glutathione. They produce way more of the toxic version, whereas those people with the high levels of glutathione, again, this in this situation of being folate deficient, they have, when they're both folate deficient and glutathione deficient, they have more toxicity. Now, conversely, people with normal levels of folic acid, the glutathione level doesn't have much impact. Okay. So can you help us with supplementation? The answer is yes. If a person's having problems with their ability to methylate, then giving methylation factors will typically help. But it's not as clean as we would like. And that is, there are some studies showing that a person has high levels of arsenic and you give them methylation support, you can actually increase toxicity. And that's based on their genetics. So I'm not going to say to you right now, everybody with arsenic should be given folate or other methylation factors. It's not that simple. By far, best is simply stop the exposure. Now, here's a concept I want to talk about. So first off, any questions before I go on the next thing? Okay, continuing on. So as I was looking at all this data showing that people with high levels of chemicals and metals in their body were having more disease, I started wondering to myself, if that's the case, can you figure out what % of each chronic disease is due to specific environmental toxins? So I hired a couple of my Rebright graduates from last year. We went diving into the research, and we found out that public health has created a formula for figuring this out. Now, this is kind of a scary mathematical formula to look into, but the idea is something called AF. That's called attributable factor, which is attributable fraction, I should say, which is basically the % of the disease. And here's a graphical way of looking at it. So I'm going to spend a couple minutes going through this. Let's take 400 people. Now, it's 400 people, let's say 100 smoke and 300 don't. You then look at what's the incidence of lung cancer in people who did not smoke. So they basically figure out this formula that I showed you here. They figure out this formula to figure out what % of lung cancer is due to cigarette smoking. So we look at the 300 non-smokers. 5% of them, or 15, will get lung cancer to factors other than cigarette smoking. Now, if they smoke, it about doubles the risk of lung cancer. Now, of course, the more they smoke, the more it's going to go up. But for the purpose of this study, and from this paper you want to dive into more deeply, you can, it doubles the risk of lung cancer. So take 100 people who are smoking, 5 of them will get lung cancer for reasons other than cigarette smoking, 5 will get lung cancer because of cigarette smoking. So the portion of lung cancer due to cigarette smoking is this little purple square here divided by everything else. So about 20% of lung cancer is due to cigarette smoking. We applied that same formula to environmental toxins and major diseases. Now, this is a very expensive process. I got a nice advance for my book, The Toxin Solution. I spent the whole advance on hiring research people to dig up this research for us. We overview Lake Washington, and at the end of Lake Washington is a seaplane port, and sometimes they go over our house. Okay, so we're going to apply the same formula to now arsenic and a bunch of diseases. So here's what we have. We have the disease name. We have the threshold. Now, there's according to the research that we looked at, and here are some example PMIDs. Every one of these has multiple PMIDs. These are just some that I thought were particularly interesting. So in that particular study, what was the threshold in the study? What % of population was above this particular threshold in this study? How much does that increase the risk of disease? Then when you plug this into this note here, when you plug this into the formula here, you then determine the % of disease. Now, I don't know about you folks, but when I saw the primary cause of gout is arsenic, I was stunned. Because it turns out when I was working in medical research, literally half a century ago, one of the things I was doing research on was gout. And I can tell you for sure, arsenic never came up as consideration for gout. Half of gout, 1/3 of prostate cancer, 1/4 of pancreatic cancer, 18% of diabetes, 14% of bladder cancer. Think about this. One factor, measurable and easy to get out of the body, causing this much trouble. Okay, any questions before I go on to the next part, which will be how do you assess arsenic body load?
I'd like to ask about the issue of rising inflammatory influences and oxidative stress as a potential factor for compromising glutathione and aggravating arsenic toxicity, and whether or not that might be a factor in COVID-19 infections.
Absolutely, 100% agreement. Okay, so I co-authored a major paper on natural medicine for COVID-19. It's in PubMed. Go get it. And we were then looking at these various factors that make people more susceptible to not just COVID-19 infection, but also the cytokine storm. And what we found was that as you increase the inflammatory baseline set point, you increase the risk going into the cytokine storm. So anything increases inflammation, then when the body has the immune reaction, it gets past the point that the body can control it, you start getting to this cascading inflammatory event. So yes, all these things contribute to each other. And something I typically start my lecture with, and I should have started with, and that is, I'm going to be talking about individual toxins. We have to realize the biggest factor is total body load of toxins because they don't function independently. They interact with each other and make each other worse. And that's one of the problems we're digging up this data on toxins and disease was you have to have independence of your factors, of your variables, because you don't have independence of your variables, it makes it harder for you to come up with percentages like this. So one of our biggest problem was you can't find any unexposed populations for your control groups. And not only that, you can't isolate one particular toxin in your group because some behind bisphenol A can be behind in phthalates as well. So that really complicated this study for us. Long answer to your question, Stephen, but hopefully that was what you were looking for.
Fine.
Any other questions?
Darrell, did you want to ask a question?
Okay, onward. Okay, so now, how do you determine a person's toxic load of arsenic? So if in a normal environment, you look at the first morning urine, and if it's more than 7 micrograms per gram of creatinine, by the way, the correlate's it's almost the same as arsenic per liter of water, a liter of urine, it's almost exactly the same. Anyway, that should start seeing toxicity. Now, if they're not in a normal environment, you want to look at the toenails, and the toenails, it's greater than 0.5 micrograms per gram of toenail. But arsenic is way more complex than any of the other toxins that I've looked at so far. So I'm going to spend a little more time diving into this. So let's look at this graphically. So this is looking at people's levels of arsenic, and this is micrograms per liter of urine. And this is US data. So about 20% of the population has more than 20 micrograms per liter of water. Another 15%, 10 to 19. So it's 25%, I talked about it before. 7 to 10, about 20%, and about 25% have relatively low levels of arsenic. So everybody has arsenic, and some of it's fairly high. So we then look at incidence of disease. If you have 20 micrograms per liter of urine, almost everybody can get some significant increase in disease. Now, if they're in this range, they're going to get disease, but they also have one of the SNPs where they don't detoxify arsenic as efficiently as they could. But what if they have both SNPs? Now, this, by the way, so 20% of the population has one SNP that makes this level more toxic. It's only 1% of the population that has both these SNPs, okay? But 1% of the population, that's what you're seeing. Those are the people you're seeing with disease. Now, here's an interesting one. If they have low levels of arsenic, but they're also fully deficient, they also get disease. So we need to start thinking about how you think about patients. So, yeah, as you know, I'm an naturopathic doctor. Naturopathic doctors are all about nurture, nurture, nurture. Conventional medicine was all about intervene, intervene, intervene. When I first put this slide together, I first said, here, well, provide nutrition. And here I said, here's more natural approaches. Here's more drug-based approach. But I was realizing that's not the right approach. The approach is, if you give the body what it needs, it can handle this. But I don't care how good the body's function, if this level of toxic, you've got to intervene. And so you think about so many areas of disease, sometimes to nurture the right approach, sometimes intervene the right approach, almost always it's a combination of both. Okay, any questions about that before we go on? Okay, continuing on. How are we doing? We're at 10:41, and that's slide 32. Oh, we're right on slide time. Okay. All right, now, so clinical application. So first off, obviously, everybody should be avoiding arsenic, pure and simple. And I'm not saying you should have no arsenic. It turns out very small amount of arsenic has been shown to have some benefit in humans. So not a lot, but for example, arsenic poisons the enzyme that converts benzene into carcinic version of benzene. So the mechanism of action by which arsenic appears to prevent the white cell cancers, because white cell cancers are highly increased by benzene. And so you actually decrease the conversion of benzene into a more toxic form. So it's kind of interesting. Okay, so anyway, anybody with arsenic levels greater than 20 micrograms per liter, they've got to avoid it. And about 2% of public water supplies and a higher percent of private wells are above the threshold already. So you just got to avoid the exposure. But now, maybe they're only having 10 micrograms per liter of water, which is bad, but what if they're also regularly eating chicken or rice, okay? Well, they've got to be intervened. If they've got the SNPs, as they have more and more of the SNPs, you've got to become more aggressive intervention. Now, how about the person has elevated homocysteine? Well, they're going to need more B vitamins because they need, remember, homocysteine, we think about homocysteine as being this bad molecule. But remember, homocysteine is like a transport and storage mechanism for sulfur compounds and for methyl groups, okay? So the methyl groups, if they're being high in homocysteine, they're having trouble with their methylation, which means they're going to have trouble with their arsenic detoxification. If a person has glutathione problems, it's got to be dealt with. You've got to clean up the water supply. Okay, so that finishes arsenic. What questions do people have about arsenic?
We have a question about what's the best way to measure it in terms of, looking at toenail tissue versus, let's say, red blood cells, hair, urine.
So right now, the best is if the person's in the normal environment, urinary, because almost all the research is on urinary arsenic. Every time I've been showing you, it's all based on urinary arsenic. So there may be other methods that are better, but in terms of what the research has looked at, it's urinary arsenic.
And how many labs do test toenails?
I don't know how many, but I do know that doctor's data will test anything you send them. Okay, any more questions about arsenic?
Water filtration. How can you lower arsenic by filtering water?
And so there is probably the reason why the public water supplies have not reported the arsenic levels. So it turns out the standard methods we use for clean up the water supply are not effective against arsenic. So for example, I have in our house a whole house carbon block filter, which is great to get rid of organic compounds and get rid of some of the metals, but metal precipitated with it as well doesn't stop arsenic. So there are some newer technologies available, but what's been commercially available in the past has been reverse osmosis and distillation. Now there's an ion exchange method that's become available. I haven't dove into it deeply enough to determine how practical it is. But up until now, those are the only two things, reverse osmosis and distillation. So as you can see why the public water supplies aren't reporting that, because that's a really expensive thing to do.
That's the questions.
Well,
Okay.
there's other questions on here too. How do you measure your progress and what kind of ion exchange?
So I don't know enough about that methodology to comment on it at this particular point. How do you measure progress? Well, the urinary levels go down and the patient's clinical presentation will improve. And if it doesn't, if either of those aren't happening, if both of those aren't happening, it means something's being missed and you've got to go dive into more deeply. Mark? Okay, let's move on to lead. I'm going to hit you over the head right now with lead. So here's a study published, I guess it's 2 years ago now. They looked at the level of lead in a person's body, typically looking at blood levels of lead. They then looked at the all-cause mortality and death from cardiovascular events. And these researchers asserted, by the way, using similar formula to what I just showed you, they assert that 18% of all cause mortality is due to lead, and 1/3 of cardiovascular mortality is due to lead. Everybody talks about cholesterol levels and cholesterol levels. Yeah, cholesterol levels that are super high are associated with heart disease. Nothing compares to this. Lead levels, dramatic increase in disease. So let's go back to that same formula I talked to you about before. Now, we haven't done as much research here, but looking at ischemic heart disease, 37%, infertility in males, 27% reduction in males, 1/3 in men, have a 27% reduction in males in their fertility due to lead levels. All-cause mortality, 67% of people are above the threshold for increasing all-cause mortality. By the way, 2 micrograms per deciliter of blood. Right now, the CDC says 10 micrograms per deciliter of lead is the safe level of lead. So this is 1/5 the level that the CDC tells us we're supposed to be avoiding, okay? So significant cause. ALS, significant cause. ADHD, in juvenile IQ, everybody knows as lead levels go down, IQ goes down. So the CDC has
The other way around.
Oh, what did I say?
You said down and down.
Oh, I'm sorry, yeah. As lead levels go up, IQ goes down. Okay, so the CDC has said 10 micrograms per deciliter. They are thinking of dropping it down to 5 for children. Here's why. Look at children with 5 micrograms per deciliter of blood versus those with 10. They have 5. Those with 10 have 5.4 IQ. Okay. So this is one example of a great public health measure that we've done, and that is we've decreased blood levels by 80% since 1970s when we started getting lead out of the environment. That's the good news. But as I look at the people on this lecture today, I see a lot of gray hair, which means all of our bones were formed when our environment was saturated with lead. So now we're seeing a situation where men and women, when they go through andropause and menopause, those lead levels go up. Not only that, but the mercury levels go up as well, because the primary storage areas of these toxic metals are the bone. You lose bone, these metals are going to go up. Interesting, one of the studies I looked at lead levels in postmenopausal women and found that those who used a hormone replacement and maintained their bones, their lead levels didn't go up. And those who did not use hormone replacement, their lead levels went up. Pretty interesting. So lead is hugely problematic, many problems. Okay, so now let's look at the same thing from the CDC, looking at lead levels. And where are the primary sources? Well, everybody knows about Flint, Michigan. A lot of the water supplies in homes and buildings have either lead pipes, that's pretty rare now, but we still have a lot of copper pipes that were put together with leaded solder. Now, that was stopped in 1987, but any house built before 1987 or remodeled before 1987 most likely has lead in the solder in the copper pipes. So if the water supply becomes corrosive or acidic, it leaches the lead out of the water. And that's what happened in Flint, Michigan. They went from the Detroit, I think it was Detroit municipal water supply that was carefully protected to their own water supply, and they apparently weren't sophisticated enough to realize what they're doing, and they put a water supply that was corrosive, and everybody's lead levels went up. Okay, so here we go. What are the threshold for increased levels of disease? Let's at least, if you use 1 microgram per deciliter of blood, that's a really, might say, safe threshold. Again, the CDC is using 10. But if we're using just 1, well, 8% of the population is above 1. And I showed you data that a level of 2, which is right about here, almost 50% of the population has 2, where I already showed you increased risk of disease. But here we got a situation where we have some positive news, and that is the work public health has done, decreasing lead in the environment has resulted in lower blood levels in the human population. So this is good progress. We went from an average over here of 1.66 down to 1.12. So about a 1/3 drop. So good news. But the problem is we still have way too much of the lead in our bodies and the water supply. Many other supplies. So lead assessment, my recommendation, this is simply blood. So you want blood level in children to be below 3 and in adults below 5. Again, there's no safe level of lead. The lower the lead, the better, period. Now, arsenic, as I said before, A level of arsenic is okay, but there's nothing okay about lead. So clinical application, number one is maintain bone. So in an older population, they're the ones who their bones are still pretty full of lead. Make sure they keep their bones. Next, if the house was built or water supply of the house was installed before 1987, or it's remodeled before that period of time, you must test the water in the home. What you want to do is go to the kitchen sink, put a container under it, and turn it on. Don't let it run for a while. Just put a container under it, turn it on, and then have it tested for lead. And unfortunately, you may be very surprised. So lead is hard to get out of the body. The half-life is measurable in basically pretty much in months. So it takes a while to get rid of it. You can facilitate that with vitamin C, with calcium, because calcium competes with it, vitamin C helps bind it. And NAC, N-acetylcysteine, probably by increasing glutathione levels, is helping get rid of lead. Now, if they have high lead and symptoms, you probably want to do an aggressive protocol. You can use oral IV EDTA or oral DMSA. Now, I'm not a great believer in IV protocols. Not that they're wrong and not that there aren't situations where they're important, but rather much higher incidence of ADRs. And so if you're not being careful, you get adverse drug reactions from this IV chelation therapy. The one I use is DMSA oral. So the protocol I use is 250 milligrams of DMSA every third day, and also add to a fiber, add to a multivitamin mineral, add to NAC, all these other things. But the DMSA oral does bind to and chelate lead out. And the reason I like the oral DMSA is that only 10% of it is absorbed. So most of the binding of the toxins actually happen in the gut. Most people don't realize that we're actually constantly dumping these metals into the gut. But because of interconnecting circulation, we reabsorb many of them. And that's happening because we don't consume enough fiber. As our detox systems evolved, we were consuming as a species 100 to 150 grams of fiber a day. Now we consume 15 to 20 grams of fiber a day. So we basically sabotage one of our key mechanisms for getting rid of many of these metals as well as many of the chemicals. Okay, that finishes what I was going to say about lead. Any questions about that?
Are lead tests that you can buy at the hardware store sufficient, or should it be a medical or more research-oriented kind of test?
Well, I don't know about those tests. What I do know is that testing for toxic metals is way more complex than most labs realize. So I mentioned to you the corporate wellness program I did, and one of the things I did was I did indeed tested the people's heavy metals both by first morning urine and by challenge testing. And we may talk about that later on if there's time. But before running 4,500 tests, I decided to test the labs. So we got to 10 of us. So the program, which I was a primary designer of, we had 7 MDs and myself were the kind of clinicians providing the services, and we had a bunch of support staff. And so we decided to all of our people was, we took all of our own samples, and then we split them in half, took samples split in half, put different names on them, and sent them to a half a dozen different labs to see what came back. And I'll tell you right now, doctor's data came back the most accurate of all of them. And I was going further, none of the other lab tests were good enough for me to use. Now my hope is that in the ensuing 10 years, since I ran that test, the other labs have improved their quality. But if these people are using one of the labs that did not have proper quality control, then they're not going to be reliable. So I'll say to you, the only way to find out is by doing some controlled testing. And that's split samples from multiple people. But there's 2 things happening here. Number one, we found that many of the labs were contaminated without them realizing it, and we got back very similar levels in all the tests. So they were measuring the background contamination, not what was actually in the samples. And then, of course, then we sent the samples. We had some labs that were just all over the place. The doctor's data, they're within 5%, all the values. So, which is what you expect from a good lab. So, in terms of those tests in the hardware store or wherever, maybe, don't know.
How about the question of doing multiple kinds of tests to see if lead is showing up in, for example, in different tissues to indicate whether or not you've got a deep tissue burden that's not showing up in your urine, or you can take a chelating agent and then see that deep tissue burden show up in your urine?
So that's the challenge. So for example, I'll be talking about mercury next. If you want to know how much mercury is causing neurological problems for a patient, you stick a needle into the brain, you take some of the brain tissue out, and you measure the amount of mercury in the brain. In general, patients don't like that idea. So we're stuck with, right, sorry, I'm a little facetious here. But we're stuck with indirect measures. And the best is actually sample the tissues, but we can't do that. So you have to use indirect measures. And that's what we're looking at here. So first morning urine for lead, for example, and blood urine are considered the gold standard for testing. And I'll share some numbers with mercury in a moment to show you that they're not very good. Challenge testing is highly controversial. What you do there is you give a person a challenge test. Take the person's first morning urine, void the urine, give them the chelating substance, collect the urine for 6 hours, and measure it again. And so the idea is one shows you current exposure, the other one tells you what's in the deep tissues, and you compare them. So the problem with the challenge testing is that it's not very good. The R values are not very good, but the R values are better than nothing. So it's better than nothing, but it's not perfect. I wish I had an easier answer for you. Any more questions? Okay, continuing on, mercury. So mercury is the one I did the most research on. Alan Markin, the guy who funded this study in Canada with his oil field workers, and it's okay to use his name because he's very public about it. We saw quite a bit of mercury, so he got quite interested in it. So as part of my contract with him, I looked at literally 2,000 articles on mercury. So I really deeply dove into mercury, and what I found was pretty shocking. So let's show you some of what's going on. So first thing we look at is mercury released into the environment, okay? And what you find is anywhere that coal is being burned for energy, you see mercury in the environment. And this gets into one of my pet peeves. Everybody's so concerned about global warming due to CO2. And I would say to you, yeah, we should be releasing CO2 into the environment, but 10 times more important, maybe 100 times more important, is actually the mercury being released in the environment from the coal burning. That's what's causing damage. So CO2, theoretical damage. Mercury, damage right now, measurable throughout our environment. And you look at good old China, 55% of the mercury being released into the environment is coming from China. They are terrible neighbors. And it's all from the coal burning in China. Now there's other sources as well, but coal burning is by far the biggest. Now another one is mercury. And it turns out the more fish people eat, the more fish people eat, the more mercury in their urine, the more mercury in their blood. This particular study, unfortunately, they didn't differentiate between low mercury fish and high mercury fish. They simply looked at how much fish people are eating. What was interesting about this study is that not only did they look at the correlation between fish meals per week and mercury in various tissues, they also looked at psychomotor dysfunction. And they found that there's an R value of 0.77 in urinary mercury and psychoneural dysfunction. That's pretty significant. Not surprising either. Because we do know that mercury primarily damages neurological tissue. It damages the thyroid and other tissues as well, but the neurological tissue damage is by far the biggest. So as you can see, even though fish has omega-3 fatty acids in it, which is beneficial, the damage from the mercury swamps the benefits from the omega-3 fatty acids. I don't think I have in this lecture a study, but in my journal, IMCJ, I published a study on the executive wellness program where they looked at mercury levels in people, omega-3 levels in their executives. What they found was that as mercury levels went up, all the benefits from omega-3s were swamped out from the mercury damage. Okay. Now, in terms of fish, this is why I was concerned about their not having differentiated between the type of fish, because there's huge difference in mercury levels between low-level mercury fish and high-level mercury fish, 1,000-fold higher. So these are 1,000. Oh, go away. Okay. Anyway, so these, by the way, all fish have some mercury in it, but this is 1,000 times as much. Problematic. Now, let's get to the question asked earlier. How about amalgams? so-called silver amalgams. Well, guess what? Silver amalgams were actually 55% mercury. They should be called mercury amalgams. And each amalgam contains almost half a gram of mercury, and each filling leaks 1 microgram of mercury into the body every day. So now the apologists for mercury in the teeth, the various dental associations, they'll show you all kinds of studies showing no correlation between fillings in the mouth and the amount of mercury in the blood, in the brain, and in the urine. But here's what's happening. They've obfuscated the data, in my opinion. And what I mean by that is, if you look at a person's mouth and you look at the fillings in the mouth, if you look at a single tooth, a tooth might have one tiny little filling, it may have multiple fillings, or the whole top of the tooth might be covered with the silver amalgam, mercury amalgam, okay? They count that as one tooth there with the filling. So we put in mixing teeth with one filling with teeth which the whole top is covered up. What you do is you increase the error range so great that statistically you wipe out the correlation between the amount of mercury in the mouth and the amount of mercury in the body. So if you instead look at surface area of mercury in the mouth, or which is hard for us clinicians to do, if you simply count the number of fillings in the mouth, and I count the whole top of the tooth with a silver filling, I count that as 6 fillings. That's just my guess. Maybe it's closer to 10, I don't know. But if you do it that way, now all the correlations pop up. So this is looking at urinary mercury and the number of the surface area of mercury in the mouth. And as you can see, it goes up very clearly, big error ranges. People have huge variation in the ability to detoxify. But basically, every filling releases about 1 microgram of mercury per day, and the average person has about 10 fillings in their mouth. So that's urine. Well, let's look at, how about brain? Okay, so this study looking at 4 different areas of the brain, looking at the number of fillings. And what they found was that as the number of fillings increases, the amount of mercury in the brain, well, you see this linear chart, you actually look at, once you have about 12 fillings, the actual ratio goes up disproportionately, because actually about 12, you've now saturated the brain's ability to get rid of mercury. Now, the apologist would say, well, maybe this is from cadavers. Once people die, maybe all of a sudden the mercury gets redistributed. Okay, well, how about live tissues? So this study came out of Finland. So I haven't read this study for a while. They basically took kidneys that were being used for transplantation. So these are live kidneys. They looked at the amount of fillings in the person's mouth. They then looked at the amount of mercury in the kidneys, and they found that the amount of mercury in the kidneys had an R value of 0.62. So the best predictor of amount of mercury in the kidneys was the number of fillings in the mouth. And they found that for each additional filling, there was 6% more mercury in the kidneys. So I can see as mercury levels go up, so does the amount of, as the amount of fillings goes up, so does the amount of mercury in the kidneys. And one would assume that representative of the whole body. Does somebody want to ask a question there?
I'd like to ask about the issue of where the filling is. It seems just as important to me as how big it is, and that is if it's on the side of the tooth where it's not a load-bearing surface and the amalgam isn't being mechanically stressed versus being on a chewing surface where it is being mechanically stressed. Why isn't that being taken into account?
That's a great question. That never occurred to me. It makes total sense. And I have not seen that in any of the research I've looked at. Like I said, I've looked at about 2,000 articles. Did not see any of them bring that up. Maybe I just missed it.
There were some questions on lead and arsenic. One person asked, can you absorb arsenic while you're in the bathtub or shower?
So transdermal. I know that you can inhale it and get it that way. Transdermal. God, I should know this. I don't know off the top of my head if you need transdermal. Sorry, I don't know. And
people are asking about what kind of filter for lead and what company is best for testing, the lead.
So all my heavy metal testing is done through doctor's data. I mean, I've now done enough studies with them. I know that they're reliable. So that's whom I use.
And for the oral DMSA, how do we get that? But I also think if we do it, we've got to do mineral supplementation because it will take all of that out as well.
So in terms of challenge testing, the dose is not high enough to cause trace mineral deficiencies, because DMSA will also bind to copper and zinc, but it's not a significant factor. Now, if you use it therapeutically over a long period of time, now you have to be more careful. But challenge testing is not anything to worry about. So when I do my challenge testing, I give people 500 milligrams of oral DMSA and 300 milligrams of oral DMPS, and that's what I've done. And all the numbers I've done have been with that kind of.
We use that as a method to detox some of the heavy metals.
Yes.
Right? Oral.
So the protocol I use for detoxifying both mercury and lead is 250 milligrams of DMSA every third night, along with fiber and a multivitamin and NAC. And I've got tons of data showing that people's levels will go down. It's slow, but you don't get ADRs.
I have a question about the issue of mercury selenide in fish, and what degree being in different places in the food chain might have to do with whether the mercury is in a selenide form or not. And have you looked at the role of, there's a selenium derivative that's found in certain fish that is cold water fish that are consumed by Inuit populations and Japanese islanders, that appears to have some kind of anti-mercury effect. Have a comment about those issues?
Yeah, very good point. And it's very clear that the selenium in fish, if there's selenium in the fish, is protective against many of these problematic things like mercury. No question about it. Now, which particular form of the selenium has the impact, I don't know, but it's true. As selenium levels go up, the mercury effects down. The same thing with omega-3 acid. As omega-3 fatty acid level, the damage from mercury goes down. But the mercury still swamps everything else.
Yeah, I suspect that if they were looking at the difference between free mercury and mercury selenide, that whatever association they would find would actually be bigger than what they're finding without looking at that consideration.
Well, I would think that as the mercury and selenium levels go up, I would think it's less toxic than mercury by itself, would be my impression, expectation.
I have a question. You talked about mercury damaging neurological tissues primarily. There was a doctor in the UK who specialized in MS. He said out of 4,000 patients, he had only seen 5 that didn't have mercury poisoning. So I'm curious, that was Patrick Kingsley, I believe. I don't think he's alive anymore. I'm wondering if you've done any research in particular on MS and mercury.
If we have time later on, I'll check my database. So with my team, we created this shared spreadsheet with across one axis, 17 cancers and 20 diseases, and across the other axis, about 50 different environmental toxins. And I don't know if we ever looked at mercury and MS. I can check my database and see what's there.
Well,
I don't think we looked at that one though.
What about this, the special toxicity of mercury to the kidney as being associated with, you did one study about that, but are there other studies that show the kidney mercury interaction in terms of kidney disease?
I have not looked at that one particularly. The one I did look at was cadmium. And the cadmium kidney disease correlation is extremely strong, and the mechanism have all been elucidated. So I suspect there's something with mercury there. I didn't run across that when I was looking at the research. One that popped up was cadmium.
Well, cadmium is isoelectronic with mercury.
Well, yeah, I would not be surprised at all. I'm just saying the research I've seen so far was cadmium. That's the problem. I spent a huge amount of money looking at this, and I basically ran out of money to do the research on it. But that's an example of what I'd love to do. If we have time later on, I'll show what a spreadsheet looks like. Anything else?
Okay.
Okay. Now here's something scary. So a friend of mine down in Melbourne, Australia, Stephen, I always botch his last name. Just to say Stephen for short, on the bottom of the slide. So Stephen, I was at an IFM conference a few years ago, and he said, I had this patient with high levels of mercury and could not figure it out. And he wasn't eating fish, didn't have a mouthful of fillings, he had all this mercury. And he said one day, he said to the patient, I want you to bring in everything that's that's going into your mouth other than food. And so he brings in this supplement, and he found out he was taking this Chinese herbal medicine. Now, the interesting thing about the Chinese herbal medicine is that you can get it in ways that bypass the Australian natural products protection mechanisms. So he decided, just for the heck of it, he would test it. So he sent over the doctor's data, and he found that the standard dose of 1 gram had 1.2 milligrams of mercury in it. That's the same as eating a chicken, a tuna steak. Okay, so he said, "Aha, look at that." Yeah, the same thing happened with another patient who was taking Ayurvedic medicine. Oh, did I miss that? Oh shoot, that slide's out of order. Go back. So he was taking Ayurvedic medicine, and we don't know how much mercury was in it. They kept diluting it, and it pegged the machine at 5,000 micrograms or 5 milligrams per gram. So, and as you probably know, mercury and other heavy metals are intentionally added to traditional Ayurvedic medicine. So if somebody's going to sell you Ayurvedic medicine for your patient, you better make sure it's not contaminated. I see why I did it this way. Okay, so now why are these Chinese herbs so contaminated? This was not intentional. It's because of the environment. Looking at this, look at this. All this mercury coming from China being released into the air from all the coal burning. So of course, Chinese herbs are going to have mercury in them because it's in the air. It's so toxic. Okay, so look at mercury and disease. We have not done a lot. So we looked at, the best ones we found initially was Hashimoto's, about 20% Hashimoto's. Not surprising since mercury causes so much damage to the thyroid. Then we saw some with ADHD, but big error ranges, and some with female infertility. There's a lot more on mercury and disease, but in terms of where we actually got all the numbers, this is what I got. But I'll tell you, dementia, Alzheimer's, all these things have very clear mercury correlations. Now, let's look at how the mercury is doing in the population. Primary sources, fish, shellfish, dental amalgams. Most toxic is going to be the methyl mercury, which comes from the fish. Of course, it's mitigated by selenium. But look at this. In terms of the threshold for known disease, and by the way, again, there's no safe level of mercury. 50% of the population has levels of mercury known to induce disease in humans. And there's another example where inexplicably it's getting worse. So I don't know why the average levels are going up, but you look at people with the highest levels, as you can see, they've gone up progressively over the period of time that we have data for them. Now, how do you assess mercury? So the first thing you see are neurological symptoms. So if somebody's coming to you with neurological symptoms, brain fog, loss of memory, dry skin and hair, anything of this nature, you must check their mercury levels. If you don't think they have mercury, check it anyway, because who knows, they may have had fillings in the past, they got removed, but their body is full of it. So blood and urine indicate current exposure. So urine should be less than 3 micrograms of mercury per gram of creatinine. But the problem with this is that if you look at, I don't think I've got this slide. If you look at blood and urine, which are the gold standard, they're accepted for mercury load in the body, the R value between the two of them is 0.3. In other words, there's very, very low correlation between how much mercury is in the blood and how much mercury is in the urine. So even though these are the standard, considered the standard of care for assessing body load, they don't correlate with each other very well, which tells me they're not very good standards for determining body load of mercury. Clinical application, get you have symptoms and amalgams, especially people with gold caps on top of mercury amalgams, they release more mercury into the body. And what you see with these patients, they have this little blue light on the gums. I've actually seen this, folks. You see this little blue light in the gums from the mercury being leached out of the fillings, and it's sped up by the gall because you perform a little battery there, dissolving the mercury more quickly. My own recommendation for people, even if they're not showing symptoms from mercury, if they've got silver fillings in the mouth, I recommend they go to an ecological dentist and have them removed. And it must be an ecological dentist. Because you go to a regular dentist, the regular dentist will say, well, I don't want to drill these things out because you release more mercury into your body, it causes more damage. And that is correct. If you drill these things out, the blood level of mercury goes up 50% and doesn't go back to normal for a year and a half. Okay, so a huge amount of mercury is released, and a bunch of it is going right into the brain. Okay, So bad news. I mean, think about it. It takes a year and a half for it to go back down, which means it got into all those other tissues and then got into those other tissues and they slowly leak into the blood for excretion. So I recommend everybody go to ecological dents because they use much greater care. They chip out the mercury. They use a lot of air filtration, good strong dams. Some will give people an IV chelating agent so that if it is any absorbed, it gets out of the body as quickly as possible. I think fish are a healthy food, but only low mercury fish. And that's easy to choose. You'll choose sardines, for example, and small salmon. They're much, much healthier. And there are multiple ways in which we increase excretion. Half-day of mercury in the body is unclear. In the blood is 1 to 3 months. In the brain, it may be as much as 10 years. But I've not been able to find good data on it. I haven't looked for a couple of years. I probably should look again. But mercury goes up fairly slowly. So you increase it by fiber. Now here's the kicker. This is a human study. So this is shown in animal studies. It's actually been reproduced in a small human study. And they were able to show that the body excretes about 1% of the body load of mercury every day into the gut and then reabsorbs 99% of it. Why would our smart bodies put all this metabolic energy to get rid of this toxic metal, then reabsorb it? Because as I said before, you got to have fiber there to bind to mercury, get out of the body. There's no fiber there, it gets reabsorbed. Okay. So eat low mercury fish, increase excretion with fiber, N-acetylcysteine. So N-acetylcysteine itself directly binds to methylmercury, but more importantly, increases the production of glutathione. And glutathione is what the brain uses to get rid of mercury. So brain basically binds glutathione to mercury and pumps across the blood-brain barrier. And then also the cells themselves, the mercury binds to glutathione in the cells and goes across cell membrane into the blood to get rid of it. So NAC is very, very helpful for mercury toxicity. Now, when you are doing these interventions I'm talking about here, you must provide trace minerals, preferably at a different time which we give the intervention, because these things will get rid of the zinc and copper. And then DMSA, oral 250 milligrams every third day. So I don't know, I don't have any of my slides here, but I'll tell you that this protocol will decrease mercury and lead about 40% in a year. You might say, well, only 40%. I'll tell you, you decrease a person's lead and mercury levels by 40%, they will notice cognitive improvement. And you keep it going. And typically, about 2 years, you've gotten rid of pretty much all of the mercury and lead, unless you continue to be exposed. And then protect against damage. There's some research showing that curcumin decreases the damage from mercury. I would think that any antioxidant, I know this, in general, antioxidants protect against damage from heavy metals like mercury. Okay, that's it for mercury until we get to next will be PCBs. Any questions?
Yeah, there's a question from a person in the audience. What effect do these toxins have in contributing to autism, particularly mercury?
Tons. Let's put it that way. So you want to get into autism and toxins, I recommend looking at the work at Sid Baker. Sid Baker, an MD, one of my good friends, and one of the brains behind the development of functional medicine. So he's an expert. He's a worldwide expert in environmental medicine. And what you find is one of the reasons why autism has been such a challenging disease is because it's a grab bag, kind of the end stage of multiple different insults to the children, and mercury toxicity being one of those. So if I have a child with mercury toxicity, I always check it. I'm sorry, if I have a child with autism, I always check them for mercury. I also always check the mitochondrial function, because it turns out that, near as I can tell, 1/4 to 1/3 of the kids with autism have a mitochondrial deficit. And if you get the mitochondria working better, it's remarkable how much the brain function improves. Any more? Okay, now let's go to PCBs. How's our time going? I'll move right along. Okay, PCBs. Sure.
What about the Safe Catch tuna? I've been buying that and eating that. They say they test the mercury in the cans. It's a canned tuna, and they test every can. They test fish, and they. Do you know anything about that? It's called Safe Catch.
So I don't know that particular company, but we do eat fish, and we do order from companies of this nature that have tested their fish for contamination. So you can get the lower contamination, but you have to spend extra for the people to test it to make sure you're getting that safe stuff, not the contaminants.
Yeah, it's expensive, more expensive.
More expensive.
Okay, thanks.
Any more? Okay, PCB. So remember from that list I showed you on from the CDC. So I've now covered 4 of the top 5 from the CDC. And PCBs are nasty. And they're nasty because they're so hard to get out of the body. So we look at arsenic, half-life 2 to 4 days, stop exposure, don't have to do much more than that. We're looking at lead. Yeah, you have to help, obviously stop exposure. You have to help the body get rid of it because you have half-life 1 to 3 months in the blood. Once it gets into the bones, about 2 to 7 years. So hard to get the lead out. Mercury, again, in the blood, 1 to 3 months. In the brain, maybe as much as 10 years, unclear. So you can get rid of it, long half-life. PCBs, half-life of PCBs in humans is 2 to 25 years. So once the stuff gets into the body, it's almost impossible to get rid of it. It causes constant damage. So let's look at this more detail. How about fish as a source of PCBs? So this was a study done in one of the Scandinavian countries, Sweden, okay? And they basically looked at the amount of fish people were consuming and the level of PCBs. And the way they looked at that objectively was they measured the amount of omega-3 fatty acids. And what they found was direct correlation between omega-3 fatty acids and the amount of PCBs. And where is Sweden getting a lot of their fish? From the Baltic Ocean, a relatively inland ocean that's had the longest exposure to industrialization of anywhere in the world, okay? And look what happens, more fish, more of these PCBs. Then you look at how about farm fish, okay? So look at farm fish versus wild fish and looking at PCB levels. This is from Ireland. I find it interesting. They talk about, oh, farm fish from Ireland, from safe, healthy Ireland. Look at the amount of PCBs in this stuff, super high. Canada, US, Scotland, all these areas that are using farmed fish have dramatically higher levels of PCBs. Okay, so clearly not good for us. Why does farm fish have so much PCBs? And by the way, the farm fish manufacturers will advertise low in mercury. And it's true, farm fish has less mercury in it. They got way more of this other crap in it. So where's it coming from? It's coming from the feed. So it turns out the more of these PCBs, DDT, PBDEs, et cetera, that are in the food supply for these fish, the more that's in the fish and the more that's in the oils made from the fish. So we're taking fish oil, it's got to be from a reliable manufacturer who actually tests the fish oil, not just for oxidation, not just for potency, omega-3 fatty acids, but also are they contaminated with fat-soluble chemicals? And these things are called persistent organic pollutants, or POPs for short. They're called persistent because they have very, very long half-life in the environment and once again to our bodies as well. And it's all from what they're being fed. Okay, now start looking at some of the disease correlations. So look at this one on cardiovascular disease in women. Just look at the increased incidence of cardiovascular events in women according to the PCB levels. Just look at a bunch of different PCBs. Now, one of the challenges with the PCBs is that there are hundreds of these things. Some PCBs, not much impact at all. Other PCBs, huge impact. So researchers tend to either look at them as a group or individually. The more you look at them as a group, the more you kind of wash out the effects. When you look at specific ones, you see big numbers. So let's look at people in the top 25% of body load. And notice this, I'm not talking about 1 out of 1,000, a rare person. I'm talking about 1/4 of our female population. Incidence of cardiovascular disease. Look at these numbers, increased risk, 10-fold increased risk, 13-fold increased risk, 10-fold increased risk. These things cause cardiovascular disease. So now start looking at some of these numbers we're able to dig up. Look at infertility. This study was done in Scandinavia where we looked at women who eat fish from the Baltic Ocean versus the Atlantic Ocean. Now, the Atlantic Ocean is by no means clean, just that the Baltic Ocean is even worse. So just that one simple thing increased the risk of infertility in women by a factor of 2.5. And we factor all this in, it looks like there's about a 50% reduction in fertility in women who eat fish from the Baltic Ocean. Male infertility, same thing. Looked at men who were able to get their spouses pregnant versus those who were not able to get their spouses pregnant or their significant other pregnant. What they found was that the PCB levels were associated with decreased fertility. Diabetes. Near as I can tell from the research, about 1/4 of diabetes is due to PCBs. Why is that? What happens is PCBs bind to the insulin receptor sites on the cells. So cells become insulin resistant. So what then happens is our wonderful pancreas has to overproduce insulin in order to force the sugar into the cells. Or you mistreat the pancreas for 20 or 30 years, it burns out and now you get diabetes. Insulin resistance. Where have you heard that before? Metabolic syndrome. Much of this is due to the environmental toxins binding to the insulin receptor site. This is just looking at PCBs. A bunch of these pops do the same thing. They bind to the insulin receptor sites and cause insulin resistance, which then results in diabetes and obesity. These researchers are calling these chemicals obesogens and diabetogens because they induce these diseases in humans. Okay. So 1/4 of diabetes, 1/4 of myocardial infarctions, rheumatoid arthritis. Now it's actually a stronger number in women. How many women with rheumatoid arthritis have you measured the PCB levels and put them on a detox program? ADHD in children. 1/6 of children have ADHD due to PCBs. And you're saying, well, wait a minute, we banned PCBs way back in 1978. That's true, we did. But the persistent organic pollutants, they're in the environment. But environment's saturated with them. They get in our bodies. If it has a half-life of 2 years, not too bad. Half-life of 25 years means once you've been exposed to it, remember, that kind of half-life thing, it takes 4 half-lives to get something out of the body. So you eat a PCB at birth, maybe from your mom, it takes you the rest of your life to get rid of it. Think about that. Okay. And that's assuming no additional exposure. Now I put these numbers here with a bit of a question mark next to them, and that is breast cancer and PCBs, extremely strong correlations. The higher the PCBs, the higher the breast cancer. And you know what? What's the best way to get PCBs out of a woman? Anyone want to guess?
Yeah, if she has a baby.
Go a little further. Take the next step.
Well, she's
breastfeeding. So it turns out breastfeeding is the most effective way of getting PCBs out of a woman. They look at a woman who's breastfed for 1 year, and it doesn't matter whether it's one baby or multiple babies, breastfeeding for 1 year decreases their PCB levels by about 1/3. So that's the good news. What's the bad news? Going into the poor babies. And it's in there for pretty much the rest of their lives. Okay, so this is hugely problematic. So I would assert one of the key reasons why breastfeeding decreases breast cancer is to get rid of the PCBs. Okay, remember, these PCBs have been in our environment for decades and decades. They were banned 50 years ago, and yet we still have these huge byloads of these things. Unfortunately, that CDC booklet I showed you, their PCB levels were screwed up. Something they made a change in their analysis in the middle, and so I couldn't rely on the numbers that they were reporting. Anyway, PCBs, huge problem. How do you diagnose them? The best way to diagnose them is doing a needle biopsy of the fat tissues. Now, patients are willing to do that. Unfortunately, we don't have labs that are measuring it anymore. You can get a better measure by looking at blood levels. And blood levels, if you correlate with the fat in the blood, are kind of an indirect measure of body load. Right now, I'm not aware of any commercial lab that's doing blood levels of PCBs. I've been asking a number of them to do that because that's going to be important. So here's a study of how you get rid of them. And it turns out that the bile sequestrants, fiber and bile sequestrants, are actually very effective at getting rid of PCBs. Anything that's going to bind cholesterol in the gut, you don't get the PCBs out. Here's a study. They didn't report how much cholesterol they gave them. It could have been 5 grams per day. I guessed 5 grams per day because once you get above about 10 grams per day, you start getting a lot of ADRs. It was a 6-month study. And what was interesting was that they found that those that got the PCBs, not a very big study, but they found that those getting PCBs had 23% reduction in PCB levels, but those who in the control group, theirs went up 24%. So it went up the same amount that the others went down. So So that tells us everybody's being constantly exposed to these PCBs, because even if the exposure is not very big, because you can't get rid of them, the levels keep going up. So just like the cholesterol, olestra, cholestyramine, all these other kinds of things, they also decrease by load of PCBs. This was looking at PCBs and DDE. They used Pringles made with olestra versus Pringles made with vegetable oil. Both showed benefit, but the Pringles with the olestra were clearly better. So assessment, blood is the best. And unfortunately, and it's better if you look at nanograms per gram of lipid in the blood, because there's an equilibration between the fat in the blood and the fat in the fat stores. So if you divide the level in the blood by the amount of fat in the blood, you get a fairly good predictor of how much is in the fat stores. About a 50% correlation factor. So it's not perfect, but it's the only thing we've got that's available. Okay, clinical application. Never, ever eat farm fish. I know a lot of people say, oh, I just eat it once a month. That's not going to be a problem. Guess what? Once a month means you will have ever increasing levels of PCBs. You can't get rid of the stuff. Okay, supplements, fiber for sure. And you want to get a lot of fiber. And I recommend up to 50 grams a day. That's going to take a while to get that up, but 50 grams a day will help get rid of that toxin. Saunas are very good. You sweat the stuff out. And if they're not, if it's high and it's not decreased with intervention, in that situation, I would then use the drug of bowel suppressants. As you know, I'm a naturopathic doctor, and even though I have the prescriptive ability to prescribe drugs, I prefer not to. And so if I can do it without using drugs, I'll do that. But if the person needs a drug, I'll give them the drug, because that's what's necessary. So with heavy metals, the MSA is a drug. I'll use it. And same with bowel suppressants. Okay, that finishes my lecture on each of these 4 toxins. Now I'm going to get into some broader discussions of intervention. So any questions at this point?
I'd like to ask if you've ever had any experience with imeramide or any of your colleagues.
What is that?
It's a mercury chelating agent invented by Dr. Boyd Haley. Is supposedly
yes,
irreversible.
Yes, I've looked into that pretty deeply, and I do not recommend it. Any other questions? Okay, moving on, intervention. So I'll now talk more about systemic intervention. So before I kind of talk about the toxins and I talk about specific interventions for the toxins, it turns out there's a number of interventions people should be using pretty much every day if you want to live a low toxin life. My wife Laura and I have gotten really, really extreme about this and have actually developed a pretty aggressive protocol for doing everything possible to avoid toxin exposure, to the point now where we're growing more and more of our own food. Okay, so with everything, always decrease exposure. Next is, we have all these great detox pathways. Now, unfortunately, many of these man-made chemicals were designed in a way to bypass the detox mechanism of the body, so they're really hard to get rid of. But nonetheless, a lot of stuff you can facilitate detox. And finally, saunas. Saunas are a very effective way of getting rid of almost all of these toxins. So let's start with eating organically grown food. I mean, so pure, simple. Organically grown versus chemically grown foods. Here's a study we've done here in Seattle, and they basically asked families who are coming out how much of their diet was eating organically grown foods versus how much of their diet was eating conventionally grown foods. They compared the kids to the kids who are eating from conventional grocery stores, Safeway, et cetera. And these people are eating from health food stores. And what they found was kids eating conventionally grown foods had 9 times higher levels of organophosphates in their urine. Why are organophosphates so important? Organophosphates are neurological poisons. If you look at children born to women in the top 10% of body load organophosphate pesticides, compare them to children born to women in the bottom 10% of organophosphate pesticides, those kids in the top 10% have a 7-point drop in IQ. 3 studies have done this now. And they iron out all the socioeconomic differences. Basically, The more organophosphate pesticides in a pregnant woman, the lower the IQ of their children and the higher the incidence of ADHD. It's scary stuff. Look at how our world seems to be coming apart. Unfortunately, we've so severely damaged the IQ of our population that they're more susceptible to manipulation. I'll just leave it at that. It's terrible what we've done to our population. Okay, so glyphosate, organically grown foods decreases glyphosate. And not only that, if you look at glyphosate, healthy people have lower levels of glyphosate than unhealthy people. When you eat conventionally grown foods, you have more glyphosate. And here's the good news. In terms of blood levels, if you stop eating conventionally grown foods, start eating organically grown foods, within 3 days, the blood levels go down to low levels. Now, the fat storage is still saturated, the brain's still saturated, but at least the blood levels are down, which is going to make it easier for the body to get out of the deeper tissue. There's also good news, and that is if you have to eat chemically grown foods, by the way, I used to use the term conventionally grown. I'm now using the term chemically grown because I want conventionally grown to become our food supply. It should be standard. Conventionally grown should always be organic. Okay, so this is looking at chemically grown foods and looking at does washing decrease pesticides, and the answer is yes. And if you're using relatively acidic washes, you decrease the amount of these toxins in the foods. And so this is looking at, they looked at chlorinated pesticide residues, and they washed with water, acid, and alkaline washes, etc. And what they found was acid washes were quite effective at significantly decreasing the amount of the toxin in the surface of these foods, which means less goes into the body. Okay, that's the last one I'm going to say about food before I move into air. Any questions about this? Okay, air. I can't overemphasize the importance of air filters, especially if you're living in the city or near a highway. So the nice thing about this is that it's a passive intervention. It means you don't have to do anything. You just install this thing, and now you got cleaner air. So recommendation is you put in a house filter for your whole house. If you've got forced air heating or forced air cooling, put a MERV filter in there. Now I recommend at least a MERV 8. We have a MERV 16 in our home. And you want to run it 24/7, all the time, always clean this out. Now, if you don't have this, or you can put a HEPA filter in the main rooms people live in. So clean air by filters, and people take off the shoes before entering the house. I don't know if I've got this, no, but actually there's research showing that if you take off your shoes, you decrease the pesticides in the house. Don't let people come in with perfumes and things. Declare a scent-free house. Filter outside air as much as possible, and put toxin-absorbing plants into the air. So I'll show you a slide on this shortly. Turns out a lot of these house plants actually clean the air, so they're a good idea to do. So here's a study. I thought this was fantastic. So they put people in a clean room for just 2 days, and this was being cleaned with a MERV 12 filter. Again, I have a MERV 16, one at least MERV 8, but there's a MERV 12. And what they found was a 33 to 58% reduction in inflammatory mediators, and people's blood pressure went down just from living in a clean room for 2 days. Now they try to keep their diet and everything else the same, it was just clean up the air. So really, really good idea. Okay, plants that absorb toxic chemicals. So it turns out, if you can determine what kind of toxin you have, you can then determine which plant is most effective. So this is looking at the percentage of chemicals being released, being removed. So mascane, pop mud, pop mum, Gerber daisy, Warnicki, I don't know what that is, ficus, and also this is water control. So ficus is actually something that's very common. It's one that we use, and it's very nice to get rid of many of these toxins. Fiber. Can't overstate the importance of fiber. I know I've said it multiple times, can't overstate. Well, there's multiple factors you can't overstate because they're critical. So remember, fiber is necessary for the liver's detox system to work properly. There's no point in conjugating this crap and dumping it into the gut via the bile if it gets reabsorbed. So fiber blocks intrahepatic recirculation. This study was done in people with non-alcoholic fatty liver disease. And they then looked at these various measures, and what they found was that as the amount of fruit fiber went up in the diet, either supplemental or dietary, the liver function of the liver improved. Okay. So it's really, really important. Next important factor is glutathione. So glutathione increase is critical because glutathione protects the body against the oxidative damage from almost every toxin. It plays a major role in getting rid of mercury from the body, but also phase 2 conjugation in the liver. Glutathione is one of the major ones for phase 2 conjugation. So it looks at the protection from free radicals, etc. So how do you get glutathione into the body? First off, oral glutathione. Little kitty, you need to move on. Okay. Anyway, so the oral glutathione will increase blood levels of glutathione, but that's a very expensive way of doing it because it's pretty much all broken down in the gut. You can stop that breakdown by either using topical or liposomal glutathione, and that can be recommended. You can also increase glutathione levels with N-acetylcysteine. So for example, 500 milligrams twice a day of NAC or 15 grams of whey powder will increase RBC glutathione by about 30%. Non-alcoholic beer, 1 pint a day will increase glutathione levels by about 15%. Resveratrol, 1 gram a day, almonds, 3 grams a day, meditation daily, and exercise, both aerobic and anaerobic, all increase glutathione levels in the body. So you want to look at one of your best strategies for helping the body protect itself from toxins and protect the mitochondria from aging. It's hard to overstate the importance of glutathione. Now you notice I don't have on here IV glutathione. Now IV glutathione is very, very useful, but before you use IV glutathione, you must make sure people don't have high levels of mercury in the blood. Because animal research shows that if high levels of mercury in the blood are given glutathione, the glutathione will take mercury into the brain. Now this is animal research. I'm not asserting it happens in humans, but I am asserting that you want to be really careful, make sure there's no mercury in a person's blood before you give them IV glutathione. Okay, that's all I'm going to say about glutathione before I move to saunas. Any questions?
Is there any fear of the redistribution just by taking oral, like liposomal glutathione or even the DMSA? That I was used to do the Cutler protocol, and that was always the fear of all this, of the redistribution of some of these of mercury.
Yeah, I think that redistribution concern is valid, and it's been well demonstrated in the animal research that it happens. So you notice the dosages I recommend are very much on the low end. So you're much less likely to get levels in the body that are going to cause redistribution. So for example, look at DMSA, only 10% is absorbed. And I'm only recommending 250 milligrams. So the chance of that causing trouble is minuscule. It's 1/10 the IV dose that's recommended. So when we're using oral dose, at 1/10 the IV dose, and only 10% is being absorbed, 1.11% of the DMSA into the body. So we're not going to see a redistribution problem as near as I can tell.
What were those doses again for DMSA and glutathione?
Oh, so the oral dose of DMSA I use is 250 milligrams every third day.
250?
250 milligrams, right. So when you look at IV, they typically use almost, it's actually 7 times as much for several days in a row. So it's just way more that's being used. And you do get ADRs when using IV, DMPS, and DMSA, which is why I don't use them.
And how about liposomal glutathione? How much would you recommend daily?
Oh, around 500 milligrams. So when we look at clinical benefit, you start getting the benefit around 250 to 500 milligrams. As near as I can tell. And again, it's all over the board depending upon the patient.
Okay, thank you.
Okay, and finally, well, not exactly finally, saunas to the rescue. Okay, there's tons of research on saunas, getting rid of metals, getting rid of chemicals. If you want to learn more about this, listen to Stephen Genuis, who's done a lot of this research. And Stephen did this study, and what he did was he took 20 normal individuals and basically had them sweat. You could either exercise, steam, or saunas. He's then scraped off their sweat and compared the toxins in their sweat to the amount of toxins in the blood, the amount of toxins in the urine, and found tons of toxins in the sweat. And so it's very good to get rid of, for example, cadmium. And this is significant because cadmium is really hard to get rid of. Because if you mobilize the cadmium, well, it ends up in the kidneys and destroys the kidneys. So you have to be very careful. Increased excretion of cadmium, increased excretion of mercury. A bunch of studies showed increased excretion of mercury. A bunch of studies look at increased excretion of PBDEs. Now, these probably diphenyl ethers. These are the chemicals we put into children's clothing to make it less flammable. Well, that sounds good, but you put the stuff in the kids' clothing, it ends up in the brains, you get more ADHD. I mean, it's just and other problems as well. Okay. And the increased secretion of PCBs. A bunch of studies have been shown. This one's looking at, I'm rushing just a little bit because I noticed I kind of got off my time thing. My cat knocked off my, what's our time? My cat knocked off my phone with my time. What time is it? Can somebody tell what time it is?
It's 11:45.
Great, okay, 15 minutes left. Okay, anyway, so you look at people using it versus those who aren't, and PCBs go down, people who are doing saunas, and then go up after they stop doing the saunas. Okay, because again, these things accumulate, constantly being exposed to. More studies looking at PCBs and getting rid of them. This one's also looked at phthalates, increased excretion of phthalates. That's the typo of this slide I have to fix. Anyway, get rid of phthalates as well. And phthalates bind to these receptor sites. So here we show a bunch of research that the toxins decrease with saunas. Is there any research on clinical benefits? And the answer is most definitely yes. Tons of research on benefit of saunas. Now here's a key factor with the sauna research I'm going to show you. They are comparing saunas 4 to 7 times per week versus once per week. So we're not looking at people who use saunas or those who use no saunas. We're using people who use saunas weekly versus those who use saunas multiple times per day. And of course, a lot of this comes out of Finland. And what they find was they're looking at all-cause mortality, cardiovascular events, etc., and everything is exactly the same. The more saunas people do, the less clinical disease they have. Now, when I looked at this, I was thinking, God, why are saunas being so effective? I started thinking to myself, and by the way, I have a 90-minute lecture just on saunas. I've looked at a lot of research on saunas. It's quite interesting. I started developing this hypothesis. As I was looking at the mechanism of action by which toxins go into the sweat, when in a sauna, and there's about 4 different mechanisms of action, and I then started looking at the mechanism of action compared to the kidneys, I think, wow, the skin has a lot of functions very similar to the kidneys. I'm thinking to myself, oh, as we evolved as a species, we evolved on the equator, in the equator. And we evolved near the equator. What's that in the equator? It's very hot, which means we're sweating a lot. Could it be that the skin is a second kidney? As we moved away from the equator into colder climes, we now have actually sabotaged this key detoxification system in the body. Interesting thought. So if you look at these diseases, cardiovascular mortality, all-cause mortality, stroke, ischemic stroke, dementia, Alzheimer's. Look at Alzheimer's disease. 65% reduction in Alzheimer's disease, those saunas 4 to 7 times per week versus those once a week. Pneumonia, respiratory tract diseases, dramatic improvements. Looking at cardiovascular disease, this now then looking at dose-dependent actions. And again, looking at once a week versus 2 to 3 times a week versus 4 to 7 times per week. As you can see, all of them all go down as saunas go up. You see why my wife and I try to sauna pretty regularly. And it turns out it's both frequency and duration are effective. So I don't have all the data here, but as I've looked at this, it looks like about 20 minutes of heavy sweating is your threshold. Once you hit that, you've got maximum benefit. Now, the benefit will still increase, but the benefit starts slowing down after about 20 minutes of sauna multiple times per week. So here's the protocol. Now, I use a little different protocol from other people because most people say what the temperature is. What I say is the temperature should be high enough to start sweating freely within 15 to 20 minutes. Now, you can do longer if you want, or lower temperatures and wait longer to sweat. But basically, it's got to be enough to be heavy sweating. You need to sweat heavily for 20 to 40 minutes. And you also want to make sure that you're drinking plenty of fluid. And the way to determine if you're drinking enough fluid is to empty your bladder, weigh yourself, go into the sauna, drink your fluids, and then weigh yourself afterwards. If you lose weight, well, you've not drunk enough fluids. So that's pretty easy to do. So I personally, I sweat about 1 pint for every 20 minutes of heavy sweating. And it's also, when you're doing these fluids, it's good if you can put in some mildly alkalinizing trace minerals. So sweating will result in loss of trace minerals, but if you're using alkalizing versions of them, like typically citrates or bicarbonates, by alkalinizing the body, You make it easier for the tissues to release the toxins, make it easier for the kidney to get rid of toxins as well. So you want about 20 to 40 minutes of heavy sweating. You want to do it at least once a week, more often if you can, and listen to the body. Now, people say, well, how about pregnant women? So the research is very clear that indeed there are some situations where women who are pregnant can get into trouble. And most of the fear about pregnancy and saunas came out of study done in pregnant. They found that high heat during the first 2 months of pregnancy, either by fever, by hot tub, or by sauna, result in increased risk of neural tube defects. But if you look at pregnant women in Finland, those who engage in regular saunas have the lowest rates of anencephaly of anywhere in the world. So the question here is not the sauna, but rather the woman's adaptation to the sauna, because it depends upon core body temperature. So when you look at the research on pregnant women having adverse events with saunas, it turns out it's totally dependent upon their core temperature. So as long as the core temperature does not go too high, they do not get adverse events. As a matter of fact, more like an improved benefit because you get rid of all those toxins. So what's the threshold? So it turns out the core temperature must not exceed 39 degrees centigrade or 102.2 degrees Fahrenheit. As long as you're below that level, you don't get adverse events from saunas. So women in Finland who regularly sauna, they have all these mechanisms by which once they're in the sauna, they're really good to get rid of excess heat. Whereas women who have not done it, they would go out with their friends when they're in the first trimester, might not even know they're pregnant, go off their friends, go in the sauna, get all hot and sweaty. Well, they're not adapted to it. Body temperature goes up too high. Well, here's the rule of thumb. If they're exercising on land, the maximum is 35 minutes at 80 to 90% of maximum heart rate at 25 degrees centigrade and 45% relative humidity. So if they exercise in water, the temperature of water determines how long they can exercise. In a hot tub, in a hot bath, I'd say 40 degrees centigrade, maximum 20 minutes. After the sauna, at 70 degrees centigrade, maximum 15, and 15% relative humidity, maximum 20 minutes. So here's a rule of thumb. So in general, saunas are safe for women unless unless it's too long, unless they're not sauna naive, and also if they have toxemia, it's recommended not to do that as well. Sauna contraindications. Now these are the official indications in the research, but it's not consistent with what you find in Finland with people regularly sauna. So they say aortic stenosis, if you have angina, severe orthostatic hypertension, recent MI are supposed to avoid saunas. But men who use saunas within 6 weeks after an MI had lower incidence of subsequent MIs. Okay. So some researchers say fever and some skin conditions are contraindications. Don't think so. Pregnancy, yes. Toxemia, don't do it, but just never let the core temperature go over 39 degrees centigrade. So clinical application, summary of what we've come up with. So before I get to my summary, any questions? Summary. So, go on.
Do you have an opinion about the relative merits of steam sauna versus dry sauna?
Oh, yes, I do. And here's my recommendation. Steam sauna would be great if they had a filter on it that was filtering out all the toxins that are coming out of the skin. If they don't have a filter, then steam sauna is probably not a good idea because you're just recirculating the toxins. Conversely, if you're in the sauna, you're sweating, you have a towel wipe off the sweat, you just got those toxins out of your body. Now, what do you do with the towels? So I mean, I've really struggled with this. So do you wash them? Okay, well, wash them, get the toxins out of the saunas, out of the towels. So now you put it into the environment. Do you burn it? Well, now you put it into the environment. Do you bury your towels? Well, yeah, now you've put it into the environment, so it's going to be longer until it gets out into the environment, but it will eventually get out into the environment. So I don't know about this part. Okay, so anyway, dry saunas are your best unless the steam sauna has really, really good filters. Anything more?
What about infrared sauna?
So near as I can tell, it doesn't matter. What counts is you've got to be sweating. So if it's infrared, is more convenient for you, fine. Whatever's most convenient. Now, of course, there can be some people who say, wait a minute, the infrared saunas can be more, maybe more risk of EMF. I don't know.
Larry, would you like to ask a question?
I'm wondering what the difference is, or if there is a difference between saunas and sweating from biking or running.
So that's the question I asked Stephen Daniels. When somebody presents such provocative research on saunas, again, we have toxins. Of course, I was the first person to raise my hand after I heard the lecture from Stephen, who, by the way, has since become a friend. And he said, it doesn't matter. All counts is, are you sweating? Now, when I look at this, the sweating that seems to be most beneficial is we start getting kind of that oily sweat. So those who've done a lot of saunas or exercise really hard, after a while, the sweat starts getting a little oily. My assumption is that's going to have the most of the toxins in it, but I don't have any data to differentiate that, to say that's true.
Thank you.
Rachel?
Hi, so I'm talking about pregnant women and using the sauna. So I was wondering what the mechanism of detox is. We're just kind of, well, I'm assuming that the toxins go out through the skin, but can they potentially cross the placenta?
Right, so the expectation is no, they're not going to. And what's fascinating is that the sauna are releasing toxins that are stored in the fat tissues out through the skin. And some of them don't even show up in the blood. The body is so sequestered with these things, it tries to get rid of them. Now, with pregnant women, if you want to be as safe as possible, and you have to be relatively toxic, not only do you avoid their toxic exposure, but give them more fiber. Because fiber means you're just getting rid of the toxins that are in the gut. You're not stirring things up inside the body. So with pregnant women, you always want to be as careful as possible. I say to pregnant women, give me a year before you get pregnant. And let me have that year to get these toxins out of your body as much as possible. Because they'll organophosphate, you can get rid of them in a year if you do it right.
Sheridan?
Hi, Dr. Pizzorno, great talk. I'm just wondering if you might give us a few other fibers other than rice bran. And do you actually do any protocol with glutathione or a push before the sauna or after the sauna? And what do you use to capture?
Yes, all great questions. So most any fiber should work. I don't use wheat fiber because too many people react to wheat. So the fiber I've actually used and I've done research on is called PGX, and that's made by Natural Factors. It's also made commercially available to doctors through BioClinic Naturals. Now, I want to be clear, I have a conflict of interest here because I'm a scientific consultant for them, okay? So I recommend their product, and that's why I used my big corporate wellness program in Canada, because I got it at a great discount. So my impression is flaxseed, any of these things should work just fine. I just used the PGX, and that was good. What was your second question?
So do you use anything to push before the sauna and then do you push, sauna, and bind? And if you do all of those things together, what are the sequence?
Yes, that's a great question. So here's an area where my own personal experience has limited some of the things I can say clinically. So as I started developing my deep dive, first off, I'm an HVAC doctor. I've always been aware of environmental toxins. Matter of fact, the very first class ever taught at the then named John Baxter College of Naturopathic Medicine, September 1978, was taught by me and was titled The Health Effects of Environmental Toxins. Okay, so I've been aware of this for a long period of time. But my biggest big data experience was doing it in corporate wellness. So when you're dealing with 4,500 people and you're testing for toxic level, I had to develop generic protocols rather than personalized protocols. So when I'm dealing with all these people where I'm not seeing them in the office regularly, like we'll do this testing of them, figure out who's high, we'll treat them, then we won't see them again for 6 months. So I had to develop protocols that were relatively safe in nature. So everything you're seeing here that I'm recommending have been used in large groups of people with very, very low ADRs. So you can become more aggressive if you want to, but my experience is, unless there's a really big clinical reason for it, you don't have to get aggressive with this. And if you do get aggressive, you're much more likely to be run into adverse events. So that's how I do it. So we did use IV chelation therapy initially with these people with high mercury levels. We used IV DMPS, and then we followed with IV glutathione. We got so many adverse events, we stopped doing it. And that's why I had to then develop this oral protocol. When we did the oral protocol, we got virtually no ADRs. And the only time we got ADRs, near as I can tell, on those people who have trouble metabolizing sulfur compounds. Because you're using sulfur compounds, but they're the ones that bind to the heavy metals. So DMSA, DMPS, NAC, they're all sulfur compounds. So if I saw somebody start getting reaction, I would then recommend they substantially increase their molybdenum consumption, because all the enzymes necessary for sulfur metabolism are dependent upon molybdenum. So I've had people with sulfur sensitivity and give them molybdenum. Took a couple of months, their sulfur sensitivity went away. Okay.
Dr. Pizzorno,
Yes.
may I ask, instead of taking a fiber supplement, can't we get enough fiber if one's eating like a very plant-based diet, or get it through vegetables and fruit?
Yes, please. Food's always better. Okay, always better. And the reality is that few people are eating enough fiber, and you can't eat a diet high in fiber like that. And so it's just pretty challenging to get above about 50. Very hard to get to 100.
Okay, thank you, Lauren. I think that's the last question. We're
Okay,
now running slightly over 2 hours, so
2 last slides. So
okay.
This is really critical. Patience, patience, patience. So think about it. Everybody's used to drug therapy with quick response, or herbal therapy with not quite so fast response. Nutritional therapy can take weeks to develop. Detoxification, you've got to give yourself months to years to get the job done. You first have to identify the toxin, stop the exposure. Then you got to get rid of the body load. And sometimes you thought they have high levels of one toxin. Well, you don't start seeing others until you got rid of that first toxin. Then for the enzyme to start working properly, you now have to get rid of all the enzymes that are poisoned by that toxin and replace them. And enzymes have half-life measured in months. And then once all this is done, then the body can start getting repaired. So it takes time. You got to be patient. So toxins are ubiquitous in the world, primary drivers of chronic disease. 4 toxins account for most of the damage. Avoidance is critical, and you can get these out of the body with these natural therapies. And there's some resources for you. Here's a resource for your patients called the Toxin Solution, where I show patients how to avoid toxins, how to make their body as effective as possible to get toxins out, get the gut working properly, the liver, the kidneys, etc. And for doctors, Walter Trini and I wrote this textbook called Clinical Environmental Medicine, where virtually everything I just showed you in this lecture is all in this textbook in great detail. There's tons of research on the role of toxins in the causing disease, and there's tons of research on how to get stuff out of the body. It's all there. We just have to use it. So thank you. Any last questions, and we're done.
Excellent. Thank you very much for a fascinating presentation. And I think that the questions that have been posted and the hand raising is all done.
Okay.
Susan, do you have a closing comment?
I want to thank you very much, because toxins are extremely important, the whole toxic soup that we're continually exposed to. And I want to thank you for helping raise awareness on this very important issues. You're wonderful.
Oh, thank you. That's very kind.
Can you email a slideshow to all of us of this presentation?
Well, I can. I
Give it to
think I
Susan.
said to Susan. Go from there. Okay.
Okay.
Anything else? Well, say goodbye, and let me go see what's going on with my cat. Cats.
Thank you
Got
all.
2 of them. Okay. Bye, everybody.
Bye, everybody.